Hi! On this last voiceover video for our chapter on the lymphatic and immune systems, we will be looking at two main themes regarding immunity. First, we will talk about primary and secondary immune responses. Then we will shift our focus on some clinical considerations. So why don't we get started right away? There are two kinds of humoral responses that we should be aware of, and these are our primary and our secondary immune responses. Let's talk about each, starting with the primary one. In primary immune response, we are encountering the antigen for the first time, and this triggers cell proliferation and differentiation. So this is the very first exposure that we have to this antigen, and the response that we see are the first exposure and what that triggers. Let's have a look at what happens. So it takes about 3 to 6 days before you start to feel sick, and it is typically around the day 10 when the peak levels of plasma antibodies are reached. After that, the antibody levels start to decline. So what is important to note here is that we meet the antigen, so the invader or pathogen if you wish, for the very first time, and the immune response takes several days to kick in. Now let's see the other scenario. In this secondary immune response, we are re-exposed to an antigen that we have seen already earlier, and we have developed a response to it earlier too. So this is really a secondary immune response in the very sense of the name of this. Well, in this case, the response is much faster, much longer, and much stronger too. So the response is within hours, not days as earlier. And notice how the peak antibody levels are present in just 2 days or so. And not only are these antibodies present at much higher levels, they also bind with much greater affinity. And this response lasts for many weeks, if not for months. So this is faster, stronger, and longer lasting response. And it is due to us having developed something called memory cells during our first encounter with this pathogen. So I think that this difference between the two is quite striking. And let's try to have a look at it a little more visually. So what I have here is a graph. On the x-axis, we have the time as days, and on the y-axis, the concentration of antibodies. And notice that the antibody concentration is shown as an exponential scale. I did not put actual numeric values there, as we are just talking in general about imaginary antigen that invades the body and triggers either a primary or secondary immune response. So let's start with our first exposure to this antigen. So this triggers an immune response, which we can see first about 3 to 6 days after the exposure, with the peak being reached around day 10. After that, the response gradually decreases. But now, what if we have a second exposure to this very same antigen? Let's have a look at that. So here is our second exposure. Remember that by this stage, we have already once met this antigen and we have developed memory cells against it. So we have a plan in place just for this kind of situations where we meet it again. Now, the secondary immune response starts within hours of the exposure, it is very fast and very strong. The amounts of antibody are significantly greater, and not only that, but it also lasts around for much longer. In fact, I ran out of space in my diagram to draw it all the way to the end. So I hope that this illustration has helped you to appreciate the differences between the primary and secondary immune responses. And we are going to move on to quickly address the concept of how humoral immunity can be either active or passive, and how it can be either naturally or artificially acquired. So let's have a look at that. Active humoral immunity occurs when an antigen is encountered, and this results in a production of specific antibodies against it. An example of naturally acquired active humoral immunity would be when this is formed in response to an actual bacterial or viral infection, whereas artificially acquired, the immunity results are as a response to vaccine that is given. And this vaccine can be either dead or inactive pathogens that are given in a dose that is manageable for the immune system, enough to develop a response without making the individual too sick. And the real beauty of this approach with vaccines is that there is no need for the symptoms of the primary response to occur. Now, we should talk about passive humoral immunity. Passive humoral immunity occurs when ready-made antibodies are introduced into the body. And again, there are two types, naturally acquired and artificially acquired passive humoral immunity. Let's have a look at these. In naturally acquired passive humoral immunity, antibodies are delivered either to the fetus via placenta or to the infant via mother's breast milk. And artificially acquired immunity was where we used injection of serum such as gamma globulin. This is an interesting approach because while it provides immediate protection, this protection ends when the antibodies naturally degrade in the body. So that is our humoral immunity. Your textbook goes into more detail about T cells, but I think that this will do for now for us in this context. What I want us to do for the rest of this video is to consider some clinical relevance that the immune system has for us. And while there are a lot, we will focus on some of the most important ones. And I want to start by talking about organ transplants. In organ transplants, the organ or tissue is removed from the donor and placed inside the recipient. And typically this is done if the recipient's original organ that is being replaced is either damaged too severely that we don't think that it is possible to fix it, or is vital to still have that organ, or if the organ is missing altogether. And there are different types of transplants. We can have a transplant from the same body from one part to another. So this is quite common. For example, before surgery, one may have his or her blood stored so that it can be given to him or her if the situation so dictates. Another typical example would be skin grafts from one part of the body to another part. What is probably most common type of transplant is an allograft. In this, organ transplant is from same species between two individuals, and typically these individuals would not be identical twins, for example. That would be a special subgroup of transplant types on its own. And then we have, of course, transplant between different species. One common example that I can think of is using pigs' heart valves that can be transplanted to humans. These are much more successful than mechanical valves, as these can grow as the size of the recipient's heart changes, unlike the mechanical valves. So this happens quite a bit as well. But like I said, allografts are probably the most common ones. And as I am sure that you know, the success of an organ transplant typically depends on the similarity of the tissues. So we are looking of as good of a match as possible. And this can be the match of the ABO blood type, other blood antigens, MHC antigens, and so on. And this is always a balancing act. We want to get as good of a match as possible to avoid rejection, but we also want to get the transplant for a person who needs it, so we do not have huge amount of luxury to spend forever waiting for the perfect match. Another thing to note, and what is relevant to this chapter, is that after the surgery, patients typically are treated with immunosuppressive therapy. So we are trying to knock out the recipient's immune system so that it does not start to reject the transplant. And while this is good for the transplant success, these individuals become now very vulnerable for all other pathogens too, and as their immune system has been brought down, this is a risk. And many of these immunosuppressive treatments have very severe side effects. And I thought that it would be fun to discuss a little bit about what are the common organs to transplant. Well, kidneys are very high on the list. In fact, one can live with just one kidney, so it is easier to find donors for these. And then we have liver transplants on the second spot. Liver has an amazing regenerative ability, so these are quite easy to find donors too. Then the heart transplants, probably not so much because of the surgery or finding donor volunteer would be easy, but more so because the heart is so important. You cannot really live without one. So doing a transplant, although risky, is often our only option. And then we have lung transplants. Again, kind of an important one to have. These numbers of transplants are from year 2000, so they are a little bit outdated, but I think that the order is still pretty accurate. And notice that we can, of course, do heart and lung transplants jointly too. And intestine transplants are less common, but still happen. So, how successful are organ transplants? Well, initially, the survival rates are okay. Look at the kidney transplants especially, while lung transplants have less successful long-term prognosis. But what I find most saddening is that although the success is initially quite good, the long-term success is much lesser. In fact, according to one study, in 10 years, about 50% of patients reject their transplants. That becomes then a decision if the 10 years is still significant additional time gained. So, like I said earlier on, the rejection is a major issue, and also the fact that when patient's immune system is suppressed, it cannot protect body from foreign pathogens such as bacterial and viral infections. In fact, infection becomes the leading cause of death in transplant patients. What I want to talk next about is immunodeficiencies. This is when the impaired production or function of immune cells happens. And this can be something that you have from the birth or that you acquire later on. And two examples that I have chosen are Hodgkin's disease and AIDS. Hodgkin's disease results in cancer of B cells, which then in turn depress lymph node cells, and in this way leads to immunodeficiency. Acquired immune deficiency syndrome, known as AIDS, then results from the human immune deficiency virus, HIV, crippling the immune system by interfering with the activity of the helper T cells. And while we have all these symptoms, it is usually opportunistic infections that lead to the death. And there is a lot we could talk about this. I have some background on this through my work, and I think that we can do so during our virtual office hours or weekly live online meeting, if you are interested. The next one that I want to mention is a large group of autoimmune diseases. In these, the immune system starts to attack itself. And there is a lot under this. For example, rheumatoid arthritis destroys joints. Myasthenia gravis impairs nerve and muscle connection. You might remember these from our earlier studies. MS, where the white myelin matter around the axons of nerve cells is destroyed. Graves' disease causing hyperthyroidism. Type 1 diabetes mellitus, which destroys pancreatic cells. Lupus, where multiple organs are affected. And then the issues with the kidneys. So how do you treat autoimmune diseases? Well, you could knock out the entire immune system, or you could try anti-inflammatory drugs such as corticosteroids. And there is a lot of promising new research in progress, so I remain optimistic that we will hopefully have soon something more effective available. So the final one that I want to mention here is hypersensitivities. Here, an over-the-top response to something that we should have relatively normally takes place. And two examples that I have mentioned here are allergies and anaphylaxis. We will not be covering the development of the immune system, but I leave that for your independent work using your textbook. So for now, this is it in terms of what I want to cover about the immune system and lymphatic system earlier on. Thank you for joining me for these videos. I know that it was a lot to cover, but as I said before, I really only expect you to have a general idea, not to be masters of these two fields. I will see you on our next module.